Health Service. Adam Brimelow is our health correspondent. We're going to hear some fairly sharp diversion of views over the next half an hour, Adam. So let's get a few facts. Actually, let's begin with the basic question. As I remember it, doctors, as part of their training, and GPs or whatever, they all go to they all work as junior doctors in hospitals.
Well, they do, and I think it's a good starting point, really, what is a junior doctor, because I think it possibly conjures up images of people who are possibly raw recruits fresh out of medical school. But in fact, the term encompasses a very wide range of roles and seniorities, so people right up to the point of about to become a consultant, people who are well into their 30s. And we heard one of those comments there from someone who said they were 34. These are people who had 5 years of medical school before embarking on their careers as junior doctors. And then you could easily have a 10-year stint going through the different roles before you go on to become a consultant, which is what most doctors are aiming at as their junior doctors. So it's people who are often in senior roles, people who are not just in their 20s but have reached their 30s and have taken on mortgages, they got families and big responsibilities in life, and they want secure pay.
Righto. Give us, if you can, your best assessment of this contract.
Well, I think there are two key points of dispute, really. Certainly, as far as the doctors are concerned, they're saying it's an enforced pay cut. It's going to force them to work longer hours. It's going to demoralise them. It's going to encourage...
Pause there a second. I always thought they really worked ridiculous. I've always spoken to doctors who, we work ridiculous hours, so even more ridiculous.
And we were getting a flavour of that, weren't we? But I think the reality is, and I don't think many people would dispute this, that the hours that junior doctors work are not like they were before the year 2000 when the current contract came in. They were considerably worse, and that contract has been successful in curbing the number of hours the doctors work.
But now we're going back to the bad old days.
Well, that's what they're saying, that part of the problem here is the removal of safeguards which had the effect of really penalising hospitals that lent on doctors to work excessive hours. So they feel that they could be working very, very long hours once again without the kind of constraints that exist at the moment, and that, they argue, will lead to obviously demoralisation and tiredness on the part of doctors, but also mistakes, errors and things that could affect patient safety.
And all this comes at a time when the government is promising 24-hour sort of care, so one assumes you need more doctors for that. So this is rather difficult if doctors are going to walk away.
Well, certainly part of the equation is that the contract needs to be attractive, and I think part of the intent, which I think probably people would recognise as being sensible, is to encourage people into those areas where there are the worst shortages, areas often where people are already spending a lot of their working time working evenings, weekends, and certainly they need to get cover on that. So people, for example, working in A&E departments, anaesthetists, also psychiatrists. And what the junior doctors are suggesting is that the changes in this proposed contract would actually penalise people of that very kind. And so I think it's important to say at this point that the NHS employers are saying that, well, okay, there are elements to this that people don't like. There are going to be winners and losers undoubtedly, but the purpose of the contract is not to save money. It's to make things better for doctors and for patients. And they say that they are ready to negotiate on these points that the doctors don't like.
But are the doctors ready to negotiate, or are they walking away from the talks at the moment?
Well, I think one problem surrounding all this is the fact that they have been told that if there's no deal, it's going to be foisted on them anyway from next summer. So that spectre of enforcement has really upped the ante, and I think has also, well, what we're seeing here is a lack of trust, really, where the employers are saying, come on, let's get back to the table. We've got a set of proposal that's flexible. We want to work with you to arrive at what's best for you and for patients. But the doctors are saying, you're trying to get us to negotiate from a set of principles that we don't agree with. And behind all this, there's the threat of enforcement, so we just don't trust you.
OK, thank you for that, Adam. That's then the background to this. Let's get some voices from those involved more closely. We're going to talk to somebody from the NHS Employers, Chief Executive of that organisation, in a moment. But I want to hear from a junior doctor called Effa Abbey first. Junior Doctor Effa, hi, good morning to you. I hear that there was a fire alarm disrupting your broadcasting a moment ago, but it's gone, we hear. So that's the first good news of the morning. Good morning to you.
Morning.
Tell us about the case. You've heard Adam spell out what he feels the background to this. Is anything that you disagree with there?
Well, I mean, I think the reason I'm against the junior contract is because I really believe that it is an attempt to systematically devalue the contribution that junior doctors up and down the country make to the NHS. I think the proposals are based on what I can only describe as a fundamental lack of understanding about how doctors work, what patients need, and what the workforce planning needs are going forward. And I think from our point of view, the public need to be very, very clear that if NHS employers are allowed to continue unchecked, they will be setting tens of thousands of caring, hard-working and motivated professionals up to fail, and the result will be an unmitigated disaster for patient safety.
OK, that's kind of a general criticism, but what is it in particular you don't like? The hours, the pay? What's the beef?
Well, I mean, there are a number of things. So, firstly, we're being asked to accept that Saturday at 9 o'clock in the evening is the same as working Tuesday at 9 o'clock in the morning, which is untrue. I mean, doctors do not come into medicine expecting not to work the weekends. There are A&E SHOs who routinely work every second weekend. We do that already. But what I do not believe NHS employers have the right to do is to tell us that that isn't a sacrifice and to stop recognising that sacrifice, which is what they're trying to do. I think NHS employers are attempting to take away safeguards which are vitally important to prevent exploitation of junior doctors. And when you have tired and demoralised junior doctors, you have unsafe care for patients.
So I understand about the Saturday evening point. What's another give me another major point, something that actually gets really, is a sticking point for you.
Well, I mean, one of the sticking points for me is that they are accepting that discrimination will be a part of the new contract. The DDRB report specifically mentions that there is potential for discrimination of certain groups in the contract. So those who engage in less than full-time training, perhaps because they have a disability or that they engage in medical research, or for females. The DDRB report actually doesn't deny that this is possible, but what they say is that it is reasonably necessary to achieve business objectives.
Well, maybe that's true. Maybe that's fair. And maybe you've got to run the place as a business. It's not, it's there to serve people, isn't it?
Yeah,
we pay money and we need the service.
Yeah, and I think I take your point, but at the moment, we do not have a contract which discriminates against these people, and therefore I would say if it doesn't happen at the moment, it's not necessary at all.
Right. Do you think the health service runs all right at the moment?
Sorry?
Do you think it's all right at the moment, the way it's organised and run? Do you think the health service is okay at the moment?
So nobody's saying that there's a perfect contract right now, but there are very good things about the contract now. And the good things about the contract now are things that we are losing in the new contract.
Okay. I'd like you to stay with us if you will, because I'm going to have talk to a couple of other people, and then I'll come back to you. And indeed, I'd like to hear texts and calls on this. They don't pay the student loan and they do get a job. They all get jobs. Their life earnings are very good, better than lots of other people, says one texter. They should be made to work for at least 5 years after qualification before going abroad. Otherwise, they're takers. Yeah, that's another point, of course, that some people do get their training here and then use it elsewhere. We've heard then the case from a doctor. I think perhaps I'd like to hear from the employers next, and I believe I can speak to Danny Mortimer, Chief Executive of NHS Employers. Hi, Danny.
Good morning, Peter.
Well, you're aware of the arguments now, and some of them have been just forcefully put. I mean, I don't want to get involved in kind of, whacking each other. I just want to hear the facts, really. I mean, give me a factual response to what you've heard.
And Aoife described very well the concerns that her and her colleagues have. I would say a few things, if I may, Peter, by way of facts. The first is the BMA have been asking for a new contract since 2008. As we've become more successful at employing more doctors and reducing the hours and types of working patterns that doctors have, or improving those, actually doctors' earnings have been falling. So there's an incentive to have a new contract for the BMA as well as for ourselves. What the government have been very clear with my organisation is that the pay bill will stay the same. This is not an exercise in saving money. There is no question that every doctor will receive a 30% cut in their
Let me get this straight. You're saying the pay bill for the service as a whole will remain the same, or the pay bill for individuals will remain the same?
So the NHS spends £3 billion on the pay bill for junior doctors.
Right.
It plans to spend about £3.1 billion
And
next
for more
year.
doctors or for the same number?
So that reflects a slight increase in the number of doctors that will employ, but also reflects the government's policy in terms of making
I haven't got the
1%
figures in
pay
front of
award.
me, but you give me the accurate answer. Is it true that in effect doctors are being paid the same under the new contract if you look at their total remuneration? If you decide the number of doctors into the total remuneration, do you come up with the same figure?
No, you don't. We would end up in a situation where there would be some doctors, and we want that to be as few doctors as possible who would see their total earnings reduce. But we want to make sure that the majority of doctors either don't lose, and there'll be a small minority that gain to reflect their working.
Why would some lose?
The way in which the banding system is set at the moment does some very strange things in the way in which we pay doctors. So there are working patterns where if you work 47 hours, you get paid the same as someone who works 40 hours. So if we change the way in which you're paid, you might well find out that the people who are working fewer hours or are perhaps less on social hours, along the lines that Aoife has described, might lose out. If I could go on and say, though, as well, Peter, employers have no interest to have a contract or hours of work that are unsafe or compromise doctors' training,
or penalise people. They penalise certain minority, women, but other people as well. I mean, do you accept that certain categories of people will lose out as a result of this new contract?
Well, let me address both points, if I may. The safety point. We have no interest in doing it, and even if employers had an interest, the enforcement and regulatory mechanisms in the NHS now are very clear. If you look at this week, the CQC inspection of Adam Brooks has been rated as an inadequate hospital because of the way in which it's deployed its staff in the view of the inspectors. There's a hospital in North London that has had 10 of its trainee doctor posts removed and given to another hospital because it's not been guaranteeing sufficient quality of training. So there are enforcement mechanisms that will be used and are used. The second point about the impact of this contract on people who take longer to complete their training. The way in which we pay junior doctors now, and doctors in general, is now relatively unique in the NHS and becoming more unique in the public sector. Yeah. Non-doctors don't have a guaranteed pay rise every year. They gain pay rises either on promotion or by passing through performance gateways, if you like. The current system pays doctors, if it takes you 10 years to complete your training, that's fine, and you'll move on to a consultant post. If it takes you longer, 12 or 15 years, your pay will continue to increase during that time. We are looking at moving to a system where actually that isn't possible anymore. We do hear the BMA's point, particularly around maternity leave and around some other career paths, but actually the 30,000 female junior doctors in this country have a benefit that the other 800,000 women working in the health service don't have.
Danny, thank you for that. Got a lot of people who want to get involved with this. I'm going to get through a few. I just had a call, for instance, from Aoife. Good morning, Aoife.
Morning.
You're a consultant.
I am a consultant. I'm a new consultant, so I passed my consultant exams in October of last year, but my partner is a junior doctor. And so I've just spent the last 10 years effectively as a junior doctor from 2005 when I qualified. And I have, along with my colleagues, seen the goalposts shift on an almost annual basis from the point at which you qualified to now. I guess a couple of points I would like to make is that it's very, I deal with the public on a day-to-day basis as patient interaction. And it is becoming more and more obvious to me, myself and my colleagues, the attitude of the general public towards what they perceive to be as greedy doctors who are set up for life, who are now just moaning about the fact that we're losing our guaranteed pay rise. That isn't, for anyone who knows a doctor, who knows a medical student, who knows someone who has a £50,000 student debt, who has spent £5,000 to £10,000 on professional exams, who spends over £1,000 a year on private indemnity and joining the GMC. For anyone who knows that, no one goes into medicine for financial gain. That's the first thing I'd like to point out.
Hang on just a second there, Effie, because it does remain true that while you don't get much in training, if you get to be a consultant, you can do very well.
Well, I'm a consultant now, and I know what my pay slip shows, and I know how much I work.
So it's
That's
not
the other thing as well. I think a lot of people are very.
You really don't think consultants do well?
About how much doctors earn.
Somebody tells me that you're going to New Zealand. Is that right?
I'm going to New Zealand for a year. Yes, I am indeed. The plan was always, even when I was training, to have a sabbatical for a year, work in another country for a year, and to come back and continue my work here. This is so that I'm not emigrating to New Zealand.
You haven't had training courtesy of this country and then taking it somewhere else, then?
Well, I've had training courtesy of this country, my parents, the taxpayers, myself a taxpayer, my £40,000 student loan fee. So yes. I mean, like every other university course that is also funded as well. Journalism, tourism, photography, they're all funded. So if people are going to go down that route, you can't pick on doctors and say that doctors
but
have
the doctor's training is, of course, expensive for you and extremely expensive for the country. So it's probably in our interest if we can retain your services.
But I think, but what people give back, and I think what people don't realise is what doctors give back when they start to work, very quickly makes up for that. Look, the point I'm trying to make is doctors are not stupid people. We're people who could do other degrees, have other careers that are much more financially remunerating. So the point I'm trying to make is this is not an argument about pay in terms of we want more pay. That is not what this is about. Because if financial gain was at the top of every doctor's list, they probably wouldn't have done medicine in the first place. So that's the first point I'd like to make. What this is about is an emasculation of the profession, a lack of respect that the government has deliberately tried to vilify doctors to make it look as if the failings of the NHS fall at the feet of doctors consultants who don't want to work weekends.
Well, the ministers aren't here, Effie, but they would very strongly refute the idea that they're vilifying.
Of course they would refute it.
I suspect that if you pan your way through consultants, you might find a good number of people who support the Conservative Party rather than attack it. But anyway.
Well, like I said, I know consultants. I work with them every day. I am one myself. I speak to people. So this is the other thing. This is about doctors getting their opinions across because we deal with this every day. I would challenge Jeremy Hunt, who maybe has never worked a Christmas day in his life, but gives himself a 10% pay rise anyway, to come and see what it's like on the shop floor. There's no point having your picture on Facebook, once in a blue moon. Come and see what it's like on the shop floor. This isn't about doctors wanting more pay. This is about respect.
Right. About respect. I'm also interested to know what impact it's had on you. When you say you're going to New Zealand, are you really coming back, or are you just going to New Zealand?
I'm coming. We're coming back. Our family, our friends are here. My partner hasn't completed his training in terms of specialist training, so yes, we're coming back. But this does affect him. This is in effect, as the junior doctor was saying on before, this is a pay cut. Call it what you'd like, but this is. I don't know if the general public know how much a junior doctor brings home every month. I know because my partner brings it home.
What is the junior?
So when my partner was working as a GP last year, when he was working as a GP, he was bringing home £1,600 a month. He was working as a full-time doctor as a GP. He was expected to see up to 30-40 patients a day. He was expected
£1,600 gross pay a month.
A month, yes.
Okay,
yes,
and how many years had he done to get to that stage?
Well, he started. That was after 6 years of medical school training and another 18 months of training postgraduately. That's what he was earning.
Well, can I ask you what you earn?
You can ask me what I earn. An NHS consultant. You can ask me what I earn. I'm not sure if I want to, publicise that on national Twitter.
Okay, it's your right. I wouldn't answer the question either. But thank you very much indeed for that. I'd cut you off only because I want to get to a lot of other people, and I've got a lot of other people to get to. But thank you for that,
Peter. May I add something at this point?
This is Danny again.
Yeah, please. Yes, it's Danny Mortimer here. There's a couple of things here. I do think that Aoife makes a really important point about a range of concerns that junior doctors have that aren't just about their pay and contracts. And we have to address those too, and we would very much welcome the BMA coming back to the table and talking to us about the contracts, but also about the other concerns that junior doctors have about the way in which they're employed and the way in which they're trained, and she touched on that. The second point to say is that there is a range of pay that junior doctors earn. They start on just less than £23,000 a year and earn a supplement on that, and then they progress through various stages. Yeah, getting
some figures here from Mike, who says 100 trainee train drivers at a vacancy advertised by ScotRail starting at 25,000, rising to 43,000. Sure. Starting pay for doctors 22,000. So which is better pay?
Which then attracts supplements, and then which rises to just shy of £70,000 by the time they're completing their training. The average earning for a junior doctor in the first 4 years of their training is £40,000 a year. The average pay for a junior doctor in that final 5 years is about £53,000 because of the way in which we pay basic and supplements.
Right, we're going to go to the news late because I haven't really got through all this yet, and I want to get here a few more voices. And if you think you're hearing a lot of Danny, it's because we're getting quite a lot of people who are attacking the employers in this, and he tends to be the voice of the employer, so necessarily he'll have a slightly longer stint at the microphone than will the others. But I'm going to lose him for a moment because I want to talk to Andrew Collier, co-chair of the British Medical Association Junior Doctors Committee. How cross are you all about this, Andrew?
Well, in my 7 years as a trainee, I've never seen my colleagues so furious with such an ill-thought-out set of proposals. What Danny's proposing to do is remove crucial safeguards on hours, put in place a system which is discriminatory against a large segment of the workforce, and for some of the hardest working trainees, pay will fall. I'm not going to pretend that junior doctors aren't well paid. We are, but that's off the back of 5 years of study. And most trainees are leaving university with debt of between £60,000 and £70,000. If we don't look after junior doctors, they're going to vote with their feet.
Yeah, do you accept, Andrew, that there is a problem here in that, NHS funding is hugely under pressure and somehow the service has to be made more competitive and just a bit more efficient? I mean, I'd be the last person to say, well, the way to do that is to cut doctors' pay, but somehow the system has to work better and maybe you have to accept changes in the way things are done.
Doctors are at the sharp end of this. So we see people in our clinics and in our accident and emergency units who know exactly what austerity means because they're facing the brunt of it. And doctors have shared in that pain. They've had a pay freeze for over 4 years. We've seen removal of free accommodation for first-year doctors, and we've seen changes to the pension system. So we know that people are hurting right now. But what we want is a system that is safe and fair for people. Doctors aren't alien to change. We do it all the time in our working lives. We put forward the best evidence, the evidence-based treatments. What we're looking at now is a contract that when you test it against the evidence, doesn't work. It doesn't work on the page and it doesn't work on the ward.
I'll come back to Danny and then I'll come back to you, Andrew, for a last thought. But Danny, you've heard again, a reasoned but passionate complaint about this deal. Perhaps it's time you started listening to these people. What do you think?
We want to listen. We want to sit down. I mean, I keep stating this, but let me be really clear about it. Both the government and ourselves as employers very much want to sit down with Andrew and his colleagues and sort this out. They've asked for a new contract. We've asked for a new contract. We believe that by working together we can receive the right result. The BMA are refusing to talk to us. From Monday onwards, I'll be travelling around the country for the next couple of months speaking to thousands of junior doctors, asking them for their views in terms of how we can resolve this situation. I would much rather, as I do with all the other trade unions that we work with, sit down and speak to the BMA. We are speaking to the BMA about the reform of the consultant contract, and I would encourage Andrew and his colleagues to take this weekend to take stock, but to come back and talk to us so that we can sort this out. Because we have no interest, I have no interest in denigrating the contribution of junior doctors. I recognise entirely what was described. I've worked in the health service now for 25 years. I recognise what was described in terms of the fantastic care and professional commitment that my junior doctor colleagues have given to patients, and then I've experienced myself in my family and in the care that my wife and I have received.
Okay, thank you for that. I'll go back to Andrew then. In the end, we're going to have to sit down and sort this out somewhere. I mean, walking away won't help, really, will it?
Completely. And it's not fair to say that the BMA has just walked away from a great offer that was on the table. So we negotiated for 2 years to get to this current position. And over that time, we saw precious little movement from government. We'd be happy to go back to negotiations if the threat of an imposition of an unfit contract is removed, and if we can have concrete assurances that the safeguards of the current contract will be remained in a future contract that could be brought in next year. But imposition and the threat of imposition must be taken away from junior doctors because they won't stand for that.
Okay, Andrew, and just a final point from you, Andrew Collier, if I may. I mean, if you don't get a deal, what's going to happen here, do you think?
Well, junior doctors feel like they're backed into a corner. We go into medicine because we want to care for our patients. Nobody wants to do anything that would put any patient at risk, but junior doctors are now faced with a very difficult decision. Do they have to take industrial action to make the government listen? Nobody wants to do that, but if the government don't listen, doctors will be given precious little choice.
You say you will go on strike?
I think doctors need to be given that decision. We've seen the anger, and as a representative of them, they need to be able to have their say in a formalised way. And so the committee tomorrow will meet to discuss whether or not a ballot will be taken on industrial action.
Right. Interesting stuff. Interesting times for all of you. Thank you very much. I hope you manage to negotiate your way out of the problem. But thank you to you, Andrew Collier, to Danny Mortimer, Chief Executive of NHS Employers, to those who've texted in, and indeed to Effie, who joined us at one stage. Been